presence of sinus membrane perforation durable. Currently, introduction of dental implant has allowed widespread use of oral surgery even in general practice and has increased the attention to surgical procedures. However, the maxillofacial region beyond the oral cavity in many aspects is undoubtedly a difficult area to approach even for oral surgeons as well as most general practitioners. A desert has barren soil and lack of living creatures. As a matter of fact, the posterior maxillar region in our jaw is similar to a desert in many ways. Poor quality containing just a fatty marrow and lack of bone quantity. Today's topic is concerning how we could make an oasis in the poor posterior maxilla so as to place dental implants. What can it do for this patient having lack of bone available and poor bone quality? There are many options in patients having the limited bone height like this. Because we are focusing on the posterior maxilla today, the available options will be short implants, tilting implants, and sinus flow augmentation. Among them, we will learn about all the sinus today. I always say to my colleagues that sinus augmentation is rather easy. You can say, what? Let me explain about it. First, I will compare sinus augmentation procedure with the guided tissue regeneration procedure, which is performed for periodontal regeneration. In terms of the tissue to regenerate, 4 tissues including gingiva, periodontal ligament, root cementum, and alveolar bone are needed to be regenerated. Those tissues are quite different in origin and progenitor cells: fibroblast, cementoblast, and osteoblast. On the other hand, for sinus augmentation, only bone tissue is needed. Very simple. Let's compare sinus augmentation procedure with GBR. GBR requires many steps of the procedure. As you can see, marrow penetration is needed in the recipient side for better blood supply. The membrane should be properly trimmed to fit the defect well. To stabilize the membrane, the fixation pins should be applied at the margin of the membrane. After bone grafting, the site should be submerged and riveting incisions should be made for tension-free closure. Each procedures are very complex and time-consuming. On the other hand, sinus augmentation procedure is relatively simple. Lateral access window will be prepared as planned, and then sinus membrane will be reflected. Finally, one substitute will be inserted into the created space. That's it. Very simple. In terms of wound closure, there are differences between 2 procedures. Because external volume increase in GBR procedure, the overlying flap should be extended. For tension-free closure, vertical incision and periostal limiting incision should be made with a special caution. In general, the incision line lies on the augmented bone mass having lack of bone supply, blood supply. So, tight sutures are needed to prevent wound dehiscence during healing. After surgery, the special wound care is needed without any pressure. Soft tissue management is very technique sensitive. It is also very stressful to clinicians as well as patients during healing phase and recall checkup. On the other hand, there is no external volume change in sinus augmentation procedure because the revision incident is not necessary and incident lies in far from the defect and lies on the native alveolar bone. Generally, wound dehiscence is rare. During healing phase, you don't have to worry about wound stabilization. Wound healing is also different between two procedures. In GBR, you need to check these points at every recall checkup visit. Once wound dehiscence occurs, the risk of wound infection due to oral bacteria is high and it has less osteogenic sources. As the surrounding tissues continues to move during speech or mastication, the augmented bone mass is hard to be stabilized. Continuous pressure by overlying flap can cause volume shrinkage. On the other hand, sinus augmentation provides much favorable environment. Primary wound closure can be easily achieved. Good blood supply and cell migration are anticipated because the gravity bone mass is entirely surrounded by native bone and sinus membrane containing periosteum. Since minimal pressure by respiration is exerted, the augmented volume can be well maintained. In this context, that's why I claim sinus augmentation is easy. However, we still have a vague fear of maxillary sinus augmentation surgery. Why so scary? There seems to be a difference in timing of the incident. In terms of complications, that of GBR is generally observed immediately post-operatively. Persistent bleeding and severe swelling, scary events occur later, or 1 week or 2 weeks later. In sinus augmentation, scary events can occur during surgery, during operation. Mostly, perforation of sinus membrane is frequent. Once it occurs, coverage is very tricky. Second, the phobia is associated with limited visibility and accessibility in sinus augmentation procedure. So, wider flap elevation and larger exposure of bone surface are needed, which lead to severe postoperative swelling and extensive bleeding sometimes. The sinus augmentation procedure has simply 2 steps: elevation of sinus membrane and bone grafting. The most difficult part of this procedure is not perforate the sinus membrane. Therefore, it is necessary to learn more about the sinus membrane. Sinus membrane, so-called Schneiderian membrane, is an important factor for containment of the grafted biomaterials as well as the osteogenic potential source itself. The Schneiderian membrane lining inside of the sinus is composed of ciliated respiratory epithelium, submucosa, containing serous gland and periosteum. Normal healthy membrane is thin, dark, grayish blue, and fragile. Chronic sinusitis or allergic rhinitis would cause mucosal change and thickness. However, physiological mucosal thickening did not contribute to or directly from failure. If mucosal thickening is greater than 9 mm in the literature, please refer to an ENT doctor, and sinus augmentation should be avoided or postponed until the pathology is addressed. Sinus epithelium has cilia, debris or foreign bodies formed during surgery can be drained out through the osteomaxilla by ciliary movement. Therefore, opening of the osteomaxilla is important to maintain the air pressure in the sinus during respiration. Patency of osteomaxilla must be confirmed on CT before surgery. Many preclinical and clinical studies demonstrated that the sinus membrane itself has high osteogenic potential. In this clinical case, you can also find the solid cortical layer formation underneath the sinus membrane after sinus augmentation. Therefore, it was observed that as long as the intact sinus membrane was well elevated by the apex of the implant, like the tenting pole, without perforation, new bone was spontaneously formed in the space below the elevated sinus membrane in numerous studies. The mean gain of the new bone height was 2 to 3 millimeters in many clinical studies when using the sinus augmentation without bone grafting. Even if no bone was inserted into the sinus, you can find the spontaneous new bone formation afterwards. Sinus has sufficient osteogenic sources from surrounding walls, but at the same time, the created space should withstand the constant air pressure. This video shows how much air pressure is applied to the sinus membrane during breathing in a rapid experiment. So special caution is needed not to perforate the sinus membrane. If not, the amount of new bone will be not enough and the apex of the implant will be exposed into the sinus. Perforation of sinus membrane is the most common complication during sinus surgery. The incidence rate varies in many studies, mostly around 20%. Although the Preston approach appears to have less occurrence of perforation than the lateral approach, in reality, it tends to be underestimated. There is controversy surrounding the effect of membrane perforation on the survival rates of implants. Contrasting opinions have been reported in papers where some claim that implants survival reduced with membrane perforation, and others claim no significant relationship exists between the two. However, maintaining the continuity of the sinus membrane is considered to be important in containment of the graft. Significantly higher prevalence of postoperative complications like sinusitis are strongly associated with large population of sinus membrane. Therefore, special caution is needed to avoid and prevent complications. In the preoperative evaluation using CT, the following items should be checked: bone quality and available bone dimension, thickness of the lateral wall, interosseous canal and lateral wall, presence of sinus septa and position, size, status of sinus mucosa, thickening and pattern, and finally, patency of the maxillary osteomaxilla. Evaluation of the thickness of the sinus membrane is key important to avoid the perforation. The thinner the sinus membrane is, the higher the risk of tears during elevation. In the patient having the thin sinus membrane, special caution is needed. The presence of sinus septa can make sinus membrane elevation difficult and increase risk of membrane perforation. Also, in the cases where presence and location of the sinus septa is unclear, hinge type of the window cannot be used. Therefore, it is crucial to figure out the location and the size of the sinus septa using CT analysis before surgery. According to the CT analysis among the Korean population, maxillary sinus septa was present in 26%, and half of these were found within the middle portion of the sinus. Sometimes we can take advantage of the thick sinus septa without additional sinus augmentation. In this patient, it was decided to extract the maxillary right molar because of endothelial failure. Even after extraction of the teeth, the bony protuberance was still remaining. This is how I avoided the invasive sinus surgery. This is another case. A large septum existed in the area where the implant was to be placed. This is another case, another patient. In this case, 2 lateral windows was made. However, it is rather too invasive for just a single implant placement. So I chose a safer way, a transcrestal approach with osteoid bone grafting, taking advantage of the thick sinus septa. A thorough preoperative evaluation and treatment planning would make minimally invasive surgery possible. However, it is very difficult to elevate the sinus membrane using a crestal approach in areas with inclined surface and undulation, and the risk of membrane perforation is high. In such circumstances, I usually use hydraulic pressure to elevate the sinus membrane. Let's take a look at this case. An implant was placed close to the septum by my resident. Several years later, it was decided to extract due to tearing of the fixture and severe bone destruction around the implant. And an implant was placed with a transcrestal approach by me. To elevate the sinus membrane, hydraulic pressure was applied. Then small amount of osteoid particle synthetic bone was grafted. The osteoid bone particles were evenly distributed at the mesial and distal side of the implant apex. These are the clinical photographs after final restoration. This is 2-year follow-up radiograph. You can compare the former and present dentin implants. As you know, sinus augmentation procedure can be classified into lateral and crestal approach. In general, which procedure to use is determined based on the remaining bone height available. As another determining factor, it is important how predictably and safely the sinus membrane can be elevated by using either the lateral window or the crescent approach. First, we will review the pros and cons of the lateral window approach. This procedure is advantageous in accessibility of instruments and visibility. And you can augment the bone height as much as desired. But it has also many disadvantages, including wide and high flap elevation for preparation of lateral window, consumption of large amount of bone substitute, and long surgical time and frequent postoperative complications. So many red boxes. All surgical techniques tend to be developed to less invasive technique. Figuratively speaking, it is like a conventional abdominal open operation, which would provide better visibility and accessibility. However, such invasive surgery would cause more postoperative complications and leave a scar. On the other hand, recent introduced robotic surgery or laparoscopic surgery, less or minimally invasive surgery compared to the conventional open surgery. What is your choice? For the less invasive technique, the crescent approach is preferred more and more. Systematic review demonstrated that the 3-year cumulative survival rate was around 93%, showing similar figures to the lateral approach. However, the crescent approach has also complications and disadvantages. On the use of crescent technique, the perforation rate of the maxillary sinus was on average 3.8%, with the postoperative infection at 0.8, less than 1%. Complications involved with the surgery is generally low. Crescent approach requires simultaneous placement of implant protruding into the sinus cavity to tent the sinus membrane and create an adequate space for blood clot formation. However, it is not always possible and may not result in a sufficient amount of newborn formation. These are clinical photographs from a dog experiment. Bacterial plaque can accumulate on the exposed implant surface in the sinus. To overcome these limitations, the use of bone graft materials is generally indicated in sinus augmentation. However, excessive use of mallet during the use of osteotome can be unpleasant for the patient. And in severe case, it can cause displacement of the otolith with damage to the vestibular function, resulting in paroxysmal positional vertigo. In spite of the less invasiveness of the crescent approach, like the blind man and elephant, visual access is limited in this procedure. The success of surgery relies on the experience and anatomical knowledge of the surgeon. Therefore, crescent approach has the downside of being a blind technique, and tapping with a mallet may cause unpleasant feeling and positional vertigo. To make a long story short, let me show you a table. The lateral approach displays the drawbacks in invasiveness and technique sensitivity, despite of good visibility, accessibility, and good augmented height. In order to overcome these drawbacks, less invasive approaches have been developed and introduced. In contrast, the crystal approach was acceptable in other criteria, but had limited visibility and augmented height. So far, there is no versatile technique to fulfill all factors in terms of predictability and invasiveness. The definition of a hybrid is the combination of two or more things for some synergy. As said previously, combining the advantages of the lateral and axial approaches could produce a synergistic effect. We need to know the actual role of the access window. The first role is a gate for instrumentation. The sinus membrane elevator is accessible through the window. The other role is a passive for bone grafting material. However, the bone substitute can be inserted crestally through the drilled hole for implants. Therefore, we just need access for the elevator instrument for sinus membrane elevation. Just using the lower part of the window will still be sufficient in elevating the sinus membrane. Let's take a look at a case. After extraction, you can observe marked vertical dimensional change in the extracted site with severe pneumatization. In the cross-sectional view, approximately 3 to 5 millimeters of bone height was available, while the ridges were enough to place implants. Let me show the video clip for such a procedure. Horizontal incision was made for flat elevation. It was extended to majorly to a neighboring popular, which is enough for access when using this technique. No need to make a vertical incision. There was plenty of bone height in the first premolar area, so I planned this implant first as a reference. And then, using a surgical stent, drilling sites were similarly marked at the location of the other implant. In case of deep lateral wall, fitting of the buccal wall was performed using this long diameter for easy preparation of access slot. And then a small piezoelectric round board is used to form an access slot. When the wall becomes sufficiently thin, it is safe to use